abatacept has shown some promise, but is not approved by NICET, as you'll probably know, so it's not in use. But all of these drugs have achieved impressive results of marked improvement in clinical symptoms and signs in the inflammatory markers, and significantly a reduction in the rate of erosive change on X-ray. Well, you'll know how they work. They're not all anti-TNF, of course, but they're geared towards fighting or reducing the levels of the pivotal cytokines, principally TNF-alpha. Infliximab and adalimumab are monoclonal antibodies which bind to TNF-alpha, and etanercept is a receptor fusion protein. This is an interesting graph which came out in the early days of use of anti-TNF drugs, produced by Professor Maney at the Kennedy Institute, Allied Charing Cross Hospital and Medical School, who did the early work on infliximab, for example. And you can see quite nicely illustrated over a period of 60 weeks the number of swollen joints, and at each peak in the graph, infliximab was given intravenously, and you see a very impressive sort of clinical response to each treatment, not only with swollen joints in terms of the C-reactive protein. So Cimzia briefly is a monoclonal antibody directed against TNF-alpha, more precisely a pegylated fragment of humanized TNF inhibitor monoclonal antibody. It's a fortnightly subcutaneous injection, and because it's available to us free for 3 months via sort of perk of the drug company, really, we're starting to use this quite a few of our patients based in Stoke with very good results so far. Golimumab, I don't know if you're familiar with this, a synthetic anti-TNF drug given by a monthly subcutaneous infusion. Tocilizumab, only very recently available. We're using it on a research basis based in Stoke and just starting in terms of the clinical basis outside the research studies. Good results so far. As you'll know, it's an IL-6 receptor monoclonal antibody. I've said earlier that the NICE guidelines indicate you can only use these drugs if the disease activity is above a certain level, 5.2, and the drugs have to be withdrawn if you don't achieve a certain response. There are side effects, of course, which you'll be well aware of. TB is one of the big things, isn't it? More over here than in the UK. They're increasing so in the UK in the large urban populations. In our cohort of 320 patients with anti-TNF drugs at Basingstoke, we've seen serious infection in just 2 or 3 cases, actually. 2 patients who died, and they were mostly atypical chest infections. So that's a worry. Thankfully, not a very common thing. I think you'll probably know much of this. The TNF drugs are really revolutionised the situation in terms of clinical response. They're not myelotoxic, which is a big attraction. They do act quickly, often very quickly. They're clearly expensive and have other difficult side effects. I haven't said very much about a remission. Criteria for remission are these. Early morning stiffness needs to be reduced. No complaint of joint pain, joint tenderness, and normal range of movement with an ESR of less than 30 over 2 months. And that seems a fairly tall order in most patients, doesn't it? But it is achievable. So what are the remission rates? Well, it was said with monotherapy it was 10 to 15%. It actually seems rather high to me. I suspect it's lower than that, and there's a natural remission rate anyway, even without treatment. Combination therapy, if organised properly and given aggressively, with good monitoring, can produce a remission rate of up to 30%. It's better with biological agents in combination with methotrexate. I'm just going to finish off by saying just a word about rituximab. I know you're going to expand on this shortly. Rituximab, as you know, is a B-cell depleter given by intravenous infusion, 2 infusions, fortnight apart. Sorry, that slide's wrong. And then given after about 9-12 months, or as when required, dictated by disease activity. It's a chimeric monoclonal antibody directed against protein CD20, which is primarily found on B cells. And its use, it's very useful in patients who have not responded to one or more other anti-TNF drugs, although there is a vogue for using it first line. And it is cheaper, as you will be aware. So, to summarise the points that I've made, the message really is that there's been a significant shift in what we know about rheumatoid arthritis. And we now know that if it's diagnosed early, you can catch patients in that window, ideally within 12 weeks of the onset of symptoms, and certainly within 3 months. And if you treat them aggressively with combination chemotherapy, in our practice we would usually use methotrexate with one other disease-modifying drug, often hydroxychloroquine, rather than necessarily introducing sulfasalazine as well. with prednisolone, the COBRA study indicated 60 milligrams of prednisolone. We tend to use lower doses, perhaps 20 to 30.